Hello everyone, my name is Dr. Shehzad Saeedullah and I am a head and neck and anterior skull based surgeon. Welcome to my YouTube channel where we take complex ideas and break them down into simplified forms for all the doctors to understand. So if that is of interest to you, please hit the like and subscribe button and hit the bell icon so that you get all the notifications from the page. So without further delay, let's get into today's video. Today we are going to be discussing a pure tone audiogram. In exams, I see a lot of my students struggling with the interpretation of an audiogram. So today we are going to take it and break it down into simple, understandable concepts. Now the question arises, why do we need an audiogram in the first place? So with the tuning fork test, we can determine what kind of a hearing loss is there, whether it is conductive hearing loss or sensorineural hearing loss. But an audiogram is going to tell us how much of a hearing loss is there. So a pure tone audiogram is basically a graph between two fundamental things in audiology. The first one is frequency, the unit for which is hertz, and the other one is loudness, the unit for which is decibels. Now, what is the difference between frequency and loudness? Let's say I take an alphabet B. If I keep on saying B, my frequency is not changing. B, 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 B. My frequency remains the same. Now, with how much force, with how much intensity I say this is going to determine the loudness. If I say this with higher force or higher intensity, B, 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 my frequency is same, but now my loudness has increased. And if I say this with low intensity or low force, B, 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 my frequency remains the same, but now my loudness has decreased. So that is in very simple terms, the way that you can explain the difference between frequency and loudness. If I take another alphabet, let's say if I take S, my frequency will now change. The frequency of S is going to be different from that of B. S, S, S. And again, with how much force am I saying this? That is going to determine the loudness of it. So each letter, each phrase, each word, it has a different frequency than another word. And as you analyze my speech is a very complex phenomenon. My speech consists of hundreds and thousands of words, and they are continuously changing at the same time. So I will take my speech, which is a combination of different frequencies, and I will break that down into simple fundamental frequencies. So the frequencies that I'm going to break down my speech in are, I will start off with 250 Hertz, then I double it, 500 Hertz, then again double it, 1000 Hertz or 1 kilohertz, then 2 kilohertz, then 4 kilohertz, and then 8 kilohertz. And again, the loudness that I'm going to be testing is 0 decibels, 10, 20, 30, 40, 50, 60, all the way to 100. So what I have done is I have taken my speech, which is a combination of different frequencies. I have broken down my speech into representative frequencies or fundamental frequencies, which are 250, which range from 250 till 8000 Hertz, and I'm going to be testing them at different levels of loudness. This is how a PTA works. This is how a pure tone audiogram works. Now how I will proceed? So I will take my first frequency, which is 250 Hertz, and I'm going to present it at a certain loudness. Let's say I present it at 10 decibels. And then I'm going to ask my patient, did he hear that sound? If the patient says yes, then I'm going to mark a point here, indicating that the patient has heard 250 Hertz at 10 decibels. If the patient says no, then I will increase my loudness to 20 decibels. And again, I'll ask my patient, did he hear the sound? So if the patient says yes, I'm going to mark a point here, which indicates that the patient has heard 250 Hertz at 20 decibels. If the patient says no, then again I will increase my loudness to 30 decibels. So this is the basic principle. I will take one fundamental frequency at a time and I present it at different loudnesses. The loudness at which the patient hears that frequency, that is where I will make a point. Then I will move on to the next frequency, which is 500 Hertz. Again, I will start off with 10 decibels. I'll ask the patient, did he hear the sound at 10 decibels? If the patient says yes, I'm going to mark a point at 10 decibels, indicating that the patient has heard 5000 Hertz at 10 decibels. If the patient says no, I will increase the loudness to 20 decibels and ask the patient, did he hear the sound? If the patient hears 500 Hz at 20 decibels, I will mark a point here. If the patient says no, I will increase the loudness to 30 decibels. My point being, you keep on increasing the loudness till the patient hears that frequency at that given loudness, and that is where you are going to mark a point. And since we are testing fundamental frequencies at any given time, I am first testing 250 Hz. I am not testing any of the other frequencies. That is why this audiogram is called a pure tone audiogram, because at any given time, I am just testing a single frequency in my complex speech that is there. So with all this information in mind, let us proceed. We know that there are two pathways by which the sound can reach cochlea. One is this pathway by which sound passes through the pinna, vibrates the tympanic membrane, the ossicle starts vibrating, and then sounds are transferred by means of oval window to the cochlea, which we call the ear conductive pathway. And the other pathway, since the cochlea is inside a bone, the sound comes, it strikes the bone starts vibrating, and those vibrations are carried to the cochlea, which we call the bone conductive pathway. So when we are doing an audiometry, or we are testing a patient for a PTA, we are going to be testing these two pathways, the ear conductive pathway and the bone conductive pathway. We are first going to give sound to the bone conductive pathway, and then we are going to present sound through the ear conductive pathway. And again, an audiogram is always in symbols. There are always symbols which are written. So the symbol for ear conduction in the right ear is a circle, and for left ear is a cross. Similarly, the symbol for bone conduction in right ear is this, and in the left ear is the inverse of this. So this is how an audiogram looks like. You are always going to see symbols. You are not going to see any words or any sentences which are going to be written on audiogram. And if you see a symbol like this, it means that this audiogram is showing you the bone conduction in the right ear. So now let us discuss the different patterns of audiogram that you may encounter. Number one, let's take a normal patient. Let's take a normal patient in which both of the pathways are working fine. I will select the bone conductive pathway. I select 250 Hz and I present it at 10 decibels. It is a normal patient, so the patient should be able to appreciate sound either at 10 decibels or 20 decibels. So I present it at 10 or 20 decibel and the patient hears the sound. I mark a point here. Then I proceed on to 500 Hz. Again, the patient hears the sound at 10 or 20 decibels because he is a normal patient. Again, I select 1000 Hz. The patient should hear at 10 or 20 decibels. 2000 Hz same, 4000 Hz same, and 8000 Hz. So in a normal patient, in a normal person, the patient should be able to hear the sounds at either 10 or 20 decibels, and it should be a straight line. When I start testing for the ear conduction pathway is going to be the same. It is either going to be completely overlapping the bone conduction or slightly below it. And it is also going to be a straight line. And the patient is going to hear sounds at 10 or 20 decibels. So such a type of graph in which the ear and bone conduction are overlapping, or the ear conduction is slightly beneath the bone conduction, and the patient is hearing the sound either at 10 decibels or 20 decibels, that is normal hearing. The ear conduction may be slightly lower than bone conduction because bone is a better conductor of sound. Now let's take scenario number 2. Let's say a patient is having a hole in the tympanic membrane, or his ossicles are dislocated, or they are not working, or they have been eaten because of infective or disease process. Now this patient has a compromised ear conductive pathway, but the bone conductive pathway which is the vibrations coming through the bone to the cochlea, is working fine. Now, how will an audiogram look like in this patient? Remember that the bone conductive pathway is normal. So let us test for the bone conductive pathway first. We will select 250 Hz. Since the bone conductive pathway is normal, the patient will be able to hear it at either at 10 decibels or 20 decibels. Then we'll select 500 Hz. And since the bone conductive pathway is normal, again the patient will either hear it at 10 decibels or 20 decibels. The same with 1000 Hz, the same with 2000, 4000, and 8000. And it is a straight line because the bone conductive pathway is intact. Now let us start testing the ear conductive pathway in this patient. Remember that the ear conductive pathway is compromised. I take 250 Hz and I present it at 10 or 20 decibel loudness. The patient will not be able to hear it because the pathway is compromised. So I have to increase my loudness. Let's say I increase it to 30 or 40. Let's say the patient hears the sound at 40 decibels. So I will mark a point here. And then I will select 500 Hz. Again, since the pathway is compromised, the patient will not be able to hear the air conduction at 10 or 20 decibels. So I have to increase the loudness. Let's say the patient hears the sound at 40 decibels. Again, I mark a point here. And the same way we test for other frequencies. And let's say the patient hears all the sounds at 40 decibels because the air conductive pathway is now compromised. So now you can see that the air conductive pathway has dropped significantly below the bone conductive pathway because there was either a hole in the tympanic membrane or the ossicles got dislocated or any of the other middle ear pathologies. So such a type of graph in which there is a visible gap between air conduction and bone conduction, which you call an air-bone gap, that indicates that the patient is having conductive deafness. So whenever you see an audiogram in which there is a visible gap between bone conduction and air conduction, which we call an air-bone gap, that signifies that the patient is having a conductive hearing loss. And how much of a conductive hearing loss? It would be the difference between the air conduction and the bone conduction. So the air conduction is starting at 40 decibels and the bone conduction is starting at 20 decibels. So 40 minus 20 equals 20 decibels. So the patient is having a conductive hearing loss of 20 decibels. Now let's consider scenario number 3. Let's consider a patient in whom the cochlea is damaged. There is cochlear damage. Whenever there is damage in the cochlea, it means that the receptors which are present inside the cochlea, their number have gone down. And the cochlea cannot appreciate the sounds that are being presented to it. So let us first consider the anatomy of cochlea. Remember, the cochlea are 2.5 turns. It is based like a pyramid, like an inverted pyramid. The bigger turns are present at the base, and as you go up, the turns become smaller and smaller. So that is how a cochlea is going to look like. It is shaped like a pyramid with the base and an apex. The base has the bigger turns, and as you go up, the turns get smaller and smaller, and from the apex is where the eighth nerve arises and carries the sound towards the brain. Since the base is the strongest part, so the higher frequencies, the receptors for the higher frequencies are present at the base. Since base is very tough, the receptors which are present here, they are very strong. So if we are to move that receptor, we need a higher force. So if this receptor is present in the base, I need to be striking it at least 8,000 times a second for it to move. That is why the higher frequencies are appreciated at the base of the cochlea. As I move up from base to the apex, the strength of the receptors, the rigidity of the receptors, it decreases. So as I move up, let's say I move to this point, here the receptor will not be as rigid. I do not need to strike it 8,000 times a second to move it. I need to strike it maybe 2,000 times or 1,000 times and it will start moving. My point being that the receptors which are present at the base, they are very rigid, and in order to move them, you need a higher frequency. That is why the higher frequencies are going to be appreciated at the base, and as you move up the cochlea, you need lower and lower force to be able to move the receptors. So 6000 hertz, 5000 hertz, 4000 hertz, 2000 hertz, 1000, and at the complete apex, maybe even 250 hertz may be able to move a receptor. So this is how the different receptors are organized along the cochlea, and the different frequencies are appreciated along the length of the cochlea, with the higher frequencies being appreciated at the base because the base receptors are strong and you need more force to be able to move those receptors, and the lower frequencies appreciated at the apex because these receptors are not as tough or rigid, and you need lower force or lower frequency to be able to move these receptors. So now whenever there is cochlear damage, most of the times the damage is at the base. This is where the damage begins, with the apex being relatively spared. So it means that the higher frequency, whenever there is cochlear damage, the higher frequencies are going to be the ones that are going to be compromised, with the lower frequencies being relatively spared because the damage in majority is happening at the base. So let's take this patient and let's see the audiogram in this patient. We start off with 250 hertz. Remember that the 250 hertz, since it is present further away from the base, it is going to be relatively spared. I select 20 decibels or 30 decibels. Since it is relatively spared, the hearing at this frequency may be preserved. So I will mark a point here. Then I will select 500 hertz. Now we are moving closer and closer towards the base. So the 500 hertz I may be able to appreciate at 35 decibels. Now I am coming down 1000 hertz. The 1000 hertz the patient may appreciate at 40 decibels, because as I am getting closer to the base, there is more and more damage. Now let's 2000 hertz. The 2000 hertz maybe the patient appreciates at 50 decibels because the receptors are now damaged. They cannot hear the sound at the normal loudness. You have to increase the loudness for them to hear sound. I move towards 4000 hertz. 4000 hertz maybe the patient hears at 60 decibels, and as I keep on going down, I need to increase my loudness because those receptors have been damaged because of the cochlear phenomenon which is taking place, maybe because of the aging or the infective process. So as I reach the complete base of the cochlea, which is 8000 hertz, maybe the patient hears 8000 hertz at 90 decibels. So if you look at the graph, the lower frequencies are going to be spared because they are farther away from the base, whereas the higher frequencies, you need to increase the loudness for the patient to be able to hear the sound because those frequencies have been involved. So such a type of graph in which the bone conduction is continuously dipping down, it shows cochlear damage. And the concept behind why this graph is going down and why do we have to increase the loudness or the higher frequencies is because most of the damage is going to be at the base. The higher frequencies are going to be the ones that are going to be involved more. So a graph in which the bone conduction is continuously dipping down, it shows sensorineural deafness. A question that I get asked from my students most of the times is there any way possible by which this graph, rather than going down, it's going to go up? So yes, there are cases in which the opposite may happen. So let's say there's a pathology which is first going to involve the apex and the base is spared. So what will happen? The graph is going to reverse. The frequencies, the lower frequencies, they are the ones going to be compromised, whereas the higher frequencies, they are going to be relatively spared. A classical example of this is Meniere's. In Meniere's disease, most of the damage is now at the apex, with the base being relatively spared. So this is an exception in which the lower frequencies are going to be involved, and the higher frequencies, since they are present at the base, they are going to be relatively spared. So in Meniere's disease, in which the damage is more at the apex, the graph may go up. But the usual presentation for patients with sensorineural deafness or cochlear damage is for the graph to go down. And that is the explanation, that is the science behind why the graph is going down. Now, another question I get asked from my students is, what will happen to air conduction? So the air conduction, again, it is either going to be completely overlapping it or slightly below it. The air conduction can never go above the bone conduction. Why? Because bone is a better conductor of sound. If the receptors in the cochlea cannot appreciate the sounds coming in through a better conductor, they will not be able to appreciate the sounds coming in through a medium which is not a better conductor. So if the receptors in cochlea cannot hear the sounds coming in through the bone, it is impossible for them to be able to appreciate the sounds coming in through the bone conduction at a higher level than bone conduction, because bone is a better conductor of sound. Coming towards the fourth scenario. So let's consider a patient in whom there is a hole in the tympanic membrane, dislocation in the ossicles, and there is also cochlear damage, which means loss of receptors. So in this patient, there is going to be a downward going bone conductive pattern, and there is also going to be ear-bone gap. So such a type of graph in which the bone conduction is going down, and along with it you also see an ear-bone gap, it means that the both of the pathways are compromised. There is a hole in the tympanic membrane or any of the pathology in the middle ear, because of which the ear conductive pathway is not working, and at the same time the cochlea is damaged too, because of which the receptors are not there and the graph is continuously going down. So such a type of graph in which the bone conduction is dipping down and there is an ear-bone gap, that indicates a mixed deafness, means to say that there is both conductive element and also sensorineural element of hearing loss to the patient. So to summarize, there are four types of graphs that you will be able to see on a pure tone audiogram. Number one, if the bone conduction and air conduction, they are overlapping at either 10 or 20 decibels, or if the air conduction is slightly beneath the bone conduction and both of them are a straight line at 10 or 20 decibels, this is normal hearing. Number two, if the bone conduction is intact, means it's either at 10 or 20 decibels and it's a straight line, but the air conduction has come down and there is a visible ear-bone gap between bone conduction and ear conduction, then it shows conductive deafness. And how much of a conductive deafness? That is the loudness at which the ear conduction is beginning minus the loudness from which the bone conduction is beginning. That is going to give you an estimate of how much of a conductive deafness is there. Number three, if you have a downward going slope or graph in which the bone conduction is continuously dipping down, with the higher frequencies being the most affected, it is showing sensorineural hearing loss, and the air conduction is either going to be overlapping this or slightly beneath it. Number four, a graph in which you will see features of both number 2 and number 3. The bone conductive pathway is continuously dipping down and there is a visible ear-bone gap between bone conduction and air conduction. That is mixed deafness, means to say it has both conductive element and also sensorineural element. Thank you everyone for watching. If there are any more complex topics that you would want us to cover, please let us know in the comment section. Thank you so much.